that's a week from today. Where you all lose your most points are on the first page, the definitions. You're a little bit too loose. You need to tighten those up. I've gone on and looked at the Quizlets. If you are not getting it on the Quizlets, you're not going to get it on the test. It correlates. I looked at what you missed as a group, and you missed them on the Quizlets, for those of you who are doing it. So pay attention to Quizlets. If the class is absolutely not getting it, it shows up on the test. So that's just a word to wise. Now, you can keep going with it. I would say the average is about 5 to 7 missed. And the majority of them come off of that first page. You do pretty good if you're given the definition. You usually can get it. Your spelling is pretty good. I don't have to take off much for spelling at all. And when you do, you lose half the points. A couple of things that you're moving away from. You're missing easy points in this area. Okay? I go off of the list that's for the chapters that give you prefix, suffix, combining forms. I don't ask you that much for word roots, but sometimes I do. Sometimes what you do is you give me the whole definition. So I look at that as that you have presented me with a multiple choice test, and I get to choose if you do it right or not. Okay, so I can't tell if you can identify that part of the word or not. Read the question carefully. If it says hemothorax, the prefix is, all I want is hemo. You don't have to define it. If I ask you what it means, then I want the definition. Okay. So most of the time I'm pretty leeway on that, but you're really sloppy when I don't know, sloppy, or it's this. So combining form, some of you all give me the answer of O. Okay. So I see that at first I thought, okay, I didn't think about it that way. That's right. I'm not making fun of you, I just never thought of it being that way. So the combining form is the word root plus usually a vowel that allows us in English to connect it to the suffix. Okay. So the combining form is the root word plus that O, A, whatever it is. Sometimes there is no vowel there because why would we not put a vowel in the combining form? The suffix starts with one. Okay. So if you'll pay attention to those, you've got points these are cheap points, so don't lose them. For the most part, you're doing okay. If you're like, I'm okay if I get 9 and I pass, that's your choice. All I'm telling you is that if you're ever if you don't want to ever take that risk, here's where you're having trouble. Use the Quizlets. About 20 of you do. So not everybody does. That's fine. If it's working for you, I don't have any problems with it. But going back and looking at the Quizlet this time, I could tell. So I would do the Quizlet until you get it right. So just some advice. Questions about that? Yes?
So when you have that first page where it says define these, let's say for the last one, I think it was like hematocrit, it was like HCT.
Yeah.
Do you want us to write out hematocrit or do you want us to define hematocrit?
When I give you an abbreviation, I just want to know what it stands for. Okay? I said that on the first test, but you all are wary, so I get it. And I don't count off for those. But that's all you have to do. If it says cabbage, all you have to do is coronary artery bypass graft. That's all. I don't have to know what it is or anything. I just want to know that you know what it stands for. That's good. Anything else? Okay. I usually watch classes, and by cardiology, I have usually got a pretty good idea of how you like material delivered, what seems to work for you. I do get a flavor for this class, but I'm not quite sure I understand how you use the objectives. Here's where it comes up. So on the asthma COPD, I gave you extremely specific because I knew it was at the end. Time was of the essence. So it's like, here's what you need to focus on. But the majority, I'd say the class missed 50% of those. The class missed them. Or the class, only half the class got it right. So then when I go to more broad, like I did with, what was the last thing we did? Arrhythmias. I don't tend to get many questions about those. So talk to me about how best material is packaged for you. My intent is there's a lot of material, and I want you to understand how to use it. I am not of the opinion that you have to figure out how to package it, so that I just don't want those things to be impediments to learning. There's enough, and I use those objectives to tell you what to focus on at this point. When you get out next year, you'll need to know more of it. But what do you need to know? I teach this course like I do to the third-year pharmacy students. You've had none of the background they've had. So you're like jumping in the deep end and never swam before. So I get it. So I'm trying to point out those things that are really important to learn. And if you'll listen to me in class, I just run them into the ground all the time. So talk to me about what works for you as a group or individually, I don't care. Yes?
I know for me, like, the more specific the objectives can be, the better. I really like having an expectation of this is what I'm intended to know, or this is what I'm expected to know, and I will do my best to know it. I think probably the later, or the closer to the test we get, the probably less specific I'm gonna know it, just because of, I try to drill things like all week long, so that I've had less time to memorize really, and like to really like own it.
Okay.
But I think that the more specific it can be, the better for my style of learning. I don't want to say for anyone else.
Okay, so when it's specific, I can overwhelm you. You can see where it gets to, 30 to plus objectives. So somebody who doesn't use them doesn't offend me at all. I'm more about how does it work for you. Tell me why you don't use them or why they don't work for you. Okay, April.
I never read your objectives just because I read it, your handout's like a book, and that's how I learn, and then I get more of a broad overview of what it is, like more of a completion, and then I can tie specifics back into it more easily. So I just try to remember everything.
Yes, it is. It's Hannah.
That's the same thing I do. I just don't ever have time to do objectives. So whenever I sit down and study Pharm, I just go through what you talk about in class and what's bolded, what's highlighted, what's underlined, and just memorize the pictures and all that stuff.
Okay. So when you are using objectives, they are never meant to say you don't have to pay attention to anything else. Usually I break down a concept into multiple pieces. So that if you learn the pieces, and then I'll usually give you an objective that says, given a patient with this, be able to identify this. And that usually requires, most of my test questions, probably, unless they're just absolutely straightforward, which I don't feel like I do that many of them that are just straight memorized. Usually you have 3 or 4 objectives, sometimes 5 that you have to bring in. Okay, all right. So, talk to me some more. What else?
I like when you
Go ahead, Jen.
I like when you mention that things are important because they're on the boards too.
Okay, now I
Even
only,
if it's not on the test, it's good to know.
I only tell you what I hear from the PA.
No,
so
right.
You know I've never taken them. Okay. I have looked at their EORs though, and I look at how they construct their stuff. So, yeah.
I've never been an objective user. I know every class is supposed to give them, but I've never looked at them. But I look at yours because I'm all about efficiency, and you make it very efficient.
Yeah.
Like I know you give us a lot of information, and it's great to know as a practicing PA, but we're not practicing yet, so it's definitely great for reference. But when it comes to like we have 1 week to get through all this information for one test, I love that I can just get through yours, and it's not something that I'm like, oh my gosh, I need to memorize every single thing on this page, but it's more focused. And then when I don't understand something that's focused, you already have that information that broadens it. So it has all the supplemental information, But when it comes to exams like this and the way our course is laid out, I think it's super duper helpful that you have it so focused.
And efficiency is one of my goals because there's just too much stuff. The other is just the basics versus the in-depth. If you understand the in-depth, all power to you, but there are some things you just gotta know and you gotta know first. Okay.
Yeah, so I use your objectives more as like a study tool. So like in class when we're going through things, I like look at the objectives and highlight what they are when you're going through it. But then when I go home, I sit down and I type it out. So I use it more as a way to study, so I can like actually be typing it and learning it that way.
Yeah,
So
last
I
year's
like
class
that.
were big on, they had those objectives nailed down. So if I didn't walk in with objectives, I always was in trouble with them. But they go through and as I'm lecturing, they write the objective number down. So,
And I started doing that at like when we first started having year lectures, and then I discovered that for me, I kind of take April's approach to when you're lecturing. I just try to like really like soak it all in, try to understand it, go through it systematically, because you're very organized in the way you present it, and highlight anything that you say is important. So kind of like combining all of those methods, and then afterwards to study, I use the objectives at that point as a focused study method to really focus my efforts.
okay. So anybody else? I am looking for feedback specific about those objectives.
This
Yes.
is the only thing I have to add. I'm almost exactly the same as Sarah. But for this last test, I literally just ran at it. For the first time.
I gave you slide number and page number.
Yeah.
That's what
All
Well,
floored
just
me
to
here.
study everything,
Yeah.
I think just,
Not just your part, the whole test.
overall,
Yeah. You rolled me over.
The way the schedule worked out, yeah.
Yes.
Yeah, it was not specific to your information,
Yeah.
it was just information as a whole. Some things just kind of got there, especially getting a lot of like stuff the day before the test. It's like that is no fault to anybody, and we definitely appreciate everything you sent out. It was just the time frame of it
Yeah.
all.
Okay.
Oh, it was super helpful. I was able to knock out those objectives so quickly.
So whenever there is no way to separate material from the test, I will always specifically tell you, here's where the objectives are, so you're not going through everything trying to find them. I don't do that on everything, but I will occasionally give them to you when things are just too tight in a time frame.
I think what was hard with the last test too was the last Pharm lecture was a very, like, asthma and COPD was very dense with Pharm, and having that right before the test, I think made it really hard. I think it would have been nicer to have that one before the weekend to give us more time to learn all of that.
I agree with you. Professor Hughes did her best, and
Yeah.
sometimes it's,
I think that was
It's
just
what
what
the
made it
outside
hard
folks
with that
do.
information, is even though the objectives were so specific, we just didn't have enough time to get through all of it with all the other material.
okay.
Yeah, I don't think there was any fault with this.
Say it again.
It was really dense material, just
Yes.
kind of like last minute.
Yeah. Okay. Someone else?
I don't know, I just said, yeah, I think the objectives were very helpful. Just the, for me, I have to start learning early. I can't just learn everything right at the last minute.
Right.
It doesn't stick in my brain
Sure.
that way. So I think that was I think it was just timing, which no one's really at fault for that. But the objectives were very helpful. I don't think it was anything with the objectives
Okay.
at all.
I agree.
Okay. So if you have things to tell me and you don't want to say it in the class, email me or come by my office. I'll be happy to hear what you have to say. And so I'm hearing that for some, the detail helps. Those who don't use them, doesn't matter how detailed I am. And I don't hear anybody complaining about the amount. So if that is a problem for you, come see me. Okay? All right, thank you. That's very helpful. Okay. So today we're going to talk about ischemic heart disease. The good news is that almost all the drugs you have heard before. Almost all the concepts you have heard before. If you can really focus on what we're talking about today, it should be a good review. Pretty much we talked about most of these drugs with acute coronary syndrome. Dr. Britton talked about some of them in hypertension. So this is at least the third time you've seen it. So hopefully that will help. And with the beta blockers, we talked about them with the antiarrhythmics. So the contraindications, the side effects are all going to be the same. Doesn't matter what you're using it for, those things tend to come up again. So if we go back to our first slide. So here again, we're looking at prevention. So these may be folks, so stable angina, these folks may, this is their only diagnosis. They don't have any other, they haven't had a bypass or a stent placement, or maybe they have. So they usually are medically managed, or they have been invasively managed, and now they're doing pretty well. So their symptoms are predictable. They usually occur, whatever brings out their chest pain usually will always bring up their chest pain, and the response to it is usually the same. So we're going to use pharmacologic and non-pharmacologic therapy to prevent them from having an event or prevent them from having the second event. Primary prevention are still people not diagnosed, high risk. That will be the majority of the people if you stay in Oklahoma, that will be a lot of what you will see in adult primary care and internal medicine. We're going to go through some of that. Just a reminder, taking back to a slide we used a couple of days ago, is that this is what we're dealing with, is those more obstructive buildup of cholesterol in the cell or in the intima of the coronary arteries, and we are having flow obstruction, which can then limit their oxygen capacity or delivery to that surrounding tissue, so that when you exceed their ability to provide that oxygen, they have symptoms. All right, so we talked about these the other day. Modifiable, need to know these. What can we modify, what can't we? So the people where we have non-modifiable risk factors, then those should be people walking in the door you're already thinking could be at higher risk for heart disease. So age. Coronary artery disease is usually a disease of aging. In men, it usually shows up about 10 years before women. Not so in the diabetic population, but in general, men over the age of 45, women over the age of 55. Gender plays a role, so males tend to be at more risk than females. Family history. So family history, we're not looking at did your grandfather at 85 have a heart attack. We're looking at the risk for premature cardiovascular disease. So what are we going to ask the person about that? There's criteria, yes.
You're going to ask if they have family members with cardiovascular disease, and ask at what age they were diagnosed, if they are still living, was it the cause of their death, and that kind of thing. Right,
so for men, for male relatives, so we're looking mostly at first degree relatives, your brother, your dad, because that's who you share the most genetic. So premature heart disease usually has a high genetic component. So that's why we're trying to identify them early. So have you had a male, your dad or your brothers have a heart, and so you name them out: heart attack, sudden death, bypass, stent, before the age of 55. And then for women, we ask before the age of 65. Okay, that identifies premature heart disease. That you need to be more aggressive with those folks. They probably have a genetic predisposition to cardiovascular disease. Personality type is really not a strong, it's not a one that you'll see a lot. I bring it up because there is data that says type A, high-strung personalities tend to have higher risk. They also may tend to drink and smoke more, so they may have other risk factors that are also. Menopausal status plays a role because usually after the age of menopause, that's when the cardiovascular risk goes up, because estrogen and levels go down, and that then the things that protected women are usually become more similar to what to men. Modifiable risk are the ones you need to pay attention to with your patients and promote those. So we've talked about diet, and we'll go into it a little bit more in the handout. Getting them to move, getting them to stop smoking. Alcohol, how much alcohol do they ingest? I've got some new data on that to share with you on those two. What are their lipid levels? People who have premature heart disease in their family often have very high LDL, or lipid disorders. Usually it's going to be a combination of LDL too high, HDL too low, and triglycerides may or may not be elevated. Yes?
So just gonna verify for, non-modifiable risk factors. We talked yesterday that females are now more at risk than males.
And like,
We were discussing it yesterday. I think, is it?
more women smoke now than men.
And now we work in higher stressed areas.
I haven't seen the study, so I don't know.
Okay, well,
what to
Reggie
do.
was talking about yesterday, so I just don't want miscommunication.
Do you want to throw something in?
There wasn't really specific reasons, I just know that whenever I went through school, they were saying that men, when you were male, that counted as one risk stratification point against you. Because I always educated my men, well, you can't change that, let's look at the things that you can change. Now they flipped it and said that women get a point, whereas men do not. So,
Where did you see that? Is it, I didn't see it in the guidelines, so I must have missed it. I just
on the risk stratification, the
Okay.
handicap.
Okay, I'll go back and look at that. The biggest non-modifiable risks are going to be gender and age and family history. Those are the big ones you need to define. The other, dyslipidemia, high blood pressure, diabetes. We're going to go through each of those and what we can do. Okay, page 3, let's look at that first. So there's primary prevention, secondary prevention. Again, primary people don't have the disease, but they may have a lot of risk factors that put them at risk. So 2 approaches. Look at, when you're giving adults, look at their risk factors. So the scope of the problem under that chart is it's the leading cause of death in the United States, coronary artery disease death. In Oklahoma, it is still #1, but we are way beyond the norm. So if you look on the first bullet, in the U.S., the heart disease rate is 179 deaths per 100,000 deaths. In Oklahoma, it's 235 per 100,000 deaths. We are the 3rd highest death rate for heart disease. Some of that goes to the factors in that come below. We're terrible in diet. We are like 50th in vegetable and fruit consumption. So our average fat intake is about 35%. The recommendation is under 30%. You see this a lot in agrarian type based economies, and that's what your older folks are coming out of it. So they had farms, or they had animals, they drank whole milk. I know Dr. Britton's dad, when we would go home and we would talk about what to have to eat, we would say, let's have chicken. And he would go up and he'd look outside and he goes, do you see any chickens out there? Because he bred cattle. So it's like, I don't know why you're talking about chickens, because what puts food on your table are those cattle out there. So the death rate in Oklahoma is 50% higher for men than it is for women. So if you look at this slide, the blue is national values. Okay, so this is looking at all races, then it's breaking it down into African American, Caucasian, Hispanic, American, Native Americans, and then Asians. So you can see there is a ethnic difference. For men are in red, women are in green, and if you look in every ethnic category, it's true. There's a 50% higher rate of heart disease in men versus women. So not that we should avoid or ignore women, but the men really, especially at younger ages, need that risk factor modification. Probably one of the biggest things that puts us at risk in Oklahoma is we have about 40% of our population is thought to have pre-diabetes. We also have a higher than average risk of diabetes. So diabetes in some guidelines is considered a cardiac equivalent, which means if you have diabetes, your risk of having a heart attack is the same as somebody who's already had a heart attack. So that's a big risk. We consider people at the highest risk are those who have already had a heart attack. Okay. So to say that somebody who has no known heart disease is at that same risk is fairly impressive. Other problems are diet. I pointed that out. We are one of the least active states. Smoking, 25% of our population smokes, 20% average. I think right now it's 19%. We are the 6th most obese state in the nation. Now, you may be sitting there and going, I'm not staying and working in this state. But what you would take away from this is that these are the things you need to look at. Every state puts out a state of the state. Oklahoma last put theirs out when I looked last year, at the end of last year in 2014. So they'll print everything out and they'll tell you by county where the problems are. Let's see, we're 44th in the average number of limited activity of days per month. So they look at people, if you're working, they'll say how many days did your health interfere with your ability to go to work, your health to do your daily chores. So we fall pretty low there. We're 43rd in the country for poor physical health days. So, in adults in this state, you gotta focus on cardiovascular risk. The modifiable, elevated cholesterol, diabetes, hypertension, obesity, and smoking account for 1/2 of the cardiovascular deaths in middle-aged and older age Americans. Now, what's that mean when we say that? It could have been avoided, so it could have been prevented. That's a big thing with cardiovascular diseases. A lot of it could be prevented. Prevention's powerful, that first statement. The preventable fraction of cardiovascular mortality associated with these risks was 54% for men, 50% for women. So they're saying for men, it's more than half of the cardiovascular disease could be prevented. For women, it's about 50%. If you look at the inner heart study, going down another bullet, it's not unique to the United States. This is a study that looked at countries, 52 countries. 9 potentially modifiable factors accounted for 90% of what was attributed to or contributed to the first heart attack. Risk factors: cigarette smoking, one of the heaviest, one of the weightiest. Hypertension, dyslipidemia, diabetes, abdominal obesity. Psychosocial factors. Factors that were associated with lower risk are listed there: regular exercise, daily consumption of fruits, vegetables, daily consumption of small amounts of alcohol, 1 drink for women, 2 for men. Recent study just came out, I just saw it this week, that looked at and says, they're based on a study that was done in actually Great Britain, they are saying maybe our alcohol limits are too high. They're not restrictive enough. So here's what they found. It was a study, it was published in Lancet, I don't know if it was last month or this month. 600,000 people they looked at. They looked at prospective studies, so they looked at studies that had, at least from a design standpoint, head strength. They looked at people who had less than 100 grams of alcohol per week. That's about equivalent to about 7 servings. It's about equivalent to what we recommend for women. The 7.5-year follow-up, so that's pretty decent that they went that far. There was a 7% increased risk of death and a 7.5 or 7% in the first event. So 14% of the people that fell into the group that drank more than 100 grams a week had an event or they died. It shortened the life expectancy at 40 by 2.5 years for men and about 1.5 years for women. Now, a lot of 40-year-olds may say, I don't care. So they may. But it calls into question is, are we too we promoted like a glass of red wine every night is heart healthy. Well, if you look at this study, it may be over the limit. So just something that people are looking for. Okay.
Even if it's a lowered risk, is it really daily consumption of alcohol?
It's in a week.
Within
They
a
looked at
while?
it in a week. How much in a week? But see, for men, they would always be over if they stayed with the limit of 2 a day.
Mhm.
Healthy diet, so these are the modifiable risk factors, I've already mentioned those. Healthy diet. So components of a healthy diet, fruits and vegetables, how many servings a day? 5 to 9. Fiber, we talked about that. What is the recommended fiber intake? Per 1,000 calories, how many grams? 14. 14 grams per 1,000. Remember, fiber is recommended based on the amount of calories taken in. If you want to use a guideline for, amount, then 25 to 35 is a good range to keep in mind if you don't want to do it by the kilocalories. Using foods that are low in glycemic index, low glycemic load. We didn't talk about that so much in diet, we'll talk about when we get to diabetes. So usually foods that have fiber in them tend to be lower in their glycemic index. So how much impact does the sugar that is in a food impact the person's response of increasing insulin? So insulin has effects that lead to weight gain, you're eating too much. Some people have implicated that in the development of atherosclerosis as well. Remember, monounsaturated fats count, the type of fats count, so what foods were high in monounsaturated fats? Olive oil, avocado, not fish foods. Nuts. Okay, so there aren't very many. So nuts, avocados, olive oil. Why do we care about monounsaturated fats? What do they do that's good? Decrease LDL, but what other lipoprotein do they really impact? HDL, they raise HDL. Omega-3 fatty acids, here's where that comes in from the fish. Smoking avoidance. Smoking still remains the leading avoidable cause of premature death and avoidable cause of premature disability. So another study came across my inbox this week about looking at, does one cigarette matter? So I thought it was really interesting because I worked with a pulmonologist, Dr. Levin, at the VA, and his thing was there is no good cigarette, ever. So when people get down to 3 or 4, he would still like, too much. And they're like, I used to smoke 2 packs a day, I'm down to 3 or 4. Well, here's what this study said. 1 cigarette a day. I wrote down a lot of stuff. Let me get my bearings here. Okay. So 1 cigarette a day accounts for 46% of excess coronary artery disease in men and women. Comparing it to a pack per day, how many cigarettes are in a pack per day? 20. Okay, so if you smoke a pack per day, your increase of cardiovascular risk in men is about, it raises men's risk from 100% to 127%. So that's a pack per day. In women, it's 184 to 295% risk. 1 cigarette a day, now listen to these. So in those who never smoke, the risk of women is 48% of developing coronary artery disease. 1 cigarette raised that risk to 74%. Sorry, that was men, sorry. For women, it was even more. For never smokers, the risk was about 57%. For those who smoked 1 cigarette, it's 119%. So 1 cigarette matters.
Just 1 cigarette.
1 cigarette, 1 cigarette. So so it may decrease the risk of lung cancer. Now that may be true. And some people, I think, tend to think more lung disease, lung cancer, than they do heart disease. Lung cancer takes a long time for that risk to go away. Cardiovascular goes away sooner. And it comes on more quickly. So the risk of cardiovascular disease really goes up within the first 2 to 3 years. And it comes off fairly quickly. Remember that list I gave you of in 5 years, here's what will your benefits of quitting smoking? So you'll get a lot of people who can get their smoking down to 1 or 2. You know, it's like they got to have that 1 cigarette when they have their coffee in the morning, or they've got to have it on the way home from work. So keep that in mind. That's new data that I saw this week.
Dr. Letassy?
Yeah.
That's 1 cigarette per day?
Yes.
You just have 1 per day?
You know, I didn't pay attention to that. I don't know if it was occasional versus 1 a day. The way I read it was 1 a day, but I didn't nail it down or write it down.
Okay. Was there anything in there about secondhand smoke?
No, not in that study. Hypertension control, most important risk factor for premature cardiovascular disease. It's a big impact because it's more common than smoking. So what did Dr. Britton tell you % of adults in the United States that have hypertension?
That was a deal.
Yeah, according to the guidelines. Okay, did he give you any other data? So a lot of people have hypertension. Only 20 to 25% smoke. So that's why they're saying it's such a big risk, is because of the number of people that have it. Hypertension accounts for 54% of all strokes, 47% of all ischemic heart disease globally. So the increase in risk comes more from systolic elevations in the elderly, diastolic elevations in the younger population. Reducing systolic 10 to 12 or diastolic 5 to 6 get pretty good reductions. 38% reduction in risk of stroke, 16% risk in coronary artery disease. The thing is, don't worry so much about those numbers. Here's the takeaway. Small steps make big impact. When we get to diabetes, we will see this again. Small reductions in weight, small reductions in blood sugar make a huge difference in the development of complications. So getting people to move towards health pays off. Okay? Even when you can't get them back to normal. Dyslipidemias, we talked about this the other day, that it's almost a linear. So every drop that you have in cholesterol, you get a big drop in heart disease. It's like for every 1% drop, you get a 2% drop in risk. So it goes for total cholesterol, also for LDL. Exercise. Strong inverse relationship between exercise and cardiovascular disease. So the more you exercise, usually the lower your risk. At all but the very highest vigorous ones. But for the majority of people, that's going to be true. So regular physical exercise reduces the odds ratio of the first MI of 0.86. What did we say odds ratio meant?
The odds of it happening in certain circumstances?
So it's the odds of something happening, whatever you're going to measure, if this factor is present. Exercise is present, does MI happen? Versus no exercise, did MI happen? So if it's less than, it's telling you it's a beneficial effect. So it's telling you that exercise does decrease the risk of an MI. This is just some data. 23% risk reduction in middle-aged men who did at least 30 minutes a day, most days of the week. Older people who walked 2 miles a day, significant lowering in mortality compared to those who didn't, who walked less than a mile. Nurses study energy expenditure, again, inversely related to coronary event. Even people who are sedentary in their middle age and pick it up still get benefits. So all activity is always a benefit. We were built to move. If we weren't, I don't think we would have all these muscles. We were meant to work. And a lot of people don't have to do that anymore. We have lots of conveniences. Did I tell you the story about a Eudora Welty? Did I give you that? So anybody know who Eudora Welty is? She's an author. She was a Southern author back in the 20s and 30s. When she died, she didn't have any kids, so her nieces and nephews went through all of her stuff. And she was known as a writer. But they found boxes of photographs. She had one of those little brownie cameras. Do you all even know what that is? Okay. And it was about this big, looked like kind of a rectangle, had that big, I don't know where the light was, the flash. So they, in the documentary I was watching of her life, I was looking at all these photos. So these were of around the time of, in between the two wars, World War I and World War II. And what struck me, and they weren't pointing it out, but nobody was overweight. She just took pictures of people in her town. And she lived in I can't remember what her hometown was. She just took pictures of the locals. The only person I saw that was even remarkably heavier than others, we would today probably say they are normal to slightly overweight. It was just a big woman. So what struck me is how much the work impacts what we weigh. And so I always told my patients, you were built to work. Please work. People who worked always did better with their diabetes than those who did not. So encourage people to get moving. There are all kinds of guidelines, and we'll talk about exercise again in diabetes. But there are all kinds of guidelines on the internet that can tell you how do you get somebody started. If somebody hasn't been exercising at all, they're kind of at risk if they start and try to really go with a vigorous exercise. A lot of them can't, but your younger people may try. But you can start off just by walking and increasing as they get tolerance without symptoms, getting them to walk. The guidelines are only 30 minutes, 5 days a week. It's not hard. Just got to get moving. Most people are not at risk to do that. One of the endocrinologists I worked with, she was like, anybody can walk. Get a good pair of shoes, anybody can walk. So that was her motto. Weight loss, obesity is overtaking cigarettes. That's huge in terms of avoidable premature death. Because now we have more overweight people than we have people who are smoking. People with diabetes, 2 to 4 times the risk. So if you are a woman with diabetes, your risk is 2 to 4 times a woman who doesn't smoke. For type 2 diabetes, 75% of those people will die of a cardiovascular event, usually. Yes?
I have a clarification question about diabetes. Are we talking type 1 and type 2 because of
Mostly type 2.
Because of the health relationship?
Type 1 tends to, their deaths usually are due to more of the microvascular complications. But mostly we're talking about type 2, they're 90% of the diabetics. Okay. Most of the ones you will see in a primary care or internal medicine are type 2.
And is that because the risks that cause them to have type 2 diabetes are also the risks that are causing a lot of the heart problems?
Well, it's genetic. It has a heavy genetic component. If your mother had diabetes, you have a 50% risk. If your both parents, you have an 80% risk. Okay. So some of it goes to risk. Then there are things that bring it on. So obesity, sedentary.
Which are the same problems.
Yes.
Okay, got it, thank you.
So what you see nowadays is people will be diagnosed with type 2 at a much younger age. Whereas in years past, it would probably have been 70 before you saw it. Because now we see it in children. So the change in what we eat, so there's a lot of research being done on additives to foods. How does that put us at risk? Our weight and our exercise. Okay, aspirin. So if we're looking at primary prevention, should we put these people on aspirin? No, only certain few. Okay. So have you all talked about the American Heart Association calculator for risk? For having an MI? 10-year risk?
Is that on Med-Cal?
Is it what?
On Med-Cal?
Yes, there's a 10-risk, Med-Cal, 10-year risk assessment on the Med-Cal.
Okay, so whether or not to treat someone depends on what is their 10-year risk. Okay. If it's low, even if they have risk factors, you're putting at more risk for a bleed than you are getting benefit from prevention.
It's the ASCVD risk calculator.
So if the 10-year risk is less than 10%, then risk is greater than benefit. We don't use aspirin for those folks. For moderate to high, if their 10-year risk is greater than 10%, you can make a call. These are primary prevention. Everybody has secondary prevention. We're going to put on an antiplatelet. We're going to put them on aspirin. So again, most places I've been, the EMR has this built in. In our clinic, since we are a diabetic clinic, we carry the calculator, and we calculate on everybody. Lifestyle changes, mood, eat healthy, lose weight, don't smoke. Easy to deliver, very hard to do. Don't give up on the message. It sometimes takes people a long time to have that epiphany that, oh, you meant me. I had patients in the lipid clinic. This taught me a lot about what patients can hear and what they don't. I had been seeing a guy in the lipid clinic in the VA for 2 years. And one day he came in and his lipids were perfect. They had been perfect any day I'd ever seen him. And I said, what did you do? And we were a comprehensive unit. We had a dietitian, we had PAs, we had nurses. We were a full-fledged cardiovascular risk reduction unit. So he had seen and talked and heard our spiel many times. So I said, what did you do? And he goes, you know what, I figured it out. What I eat raises my cholesterol. Now I've been speaking of foreign language all this time. So sometimes I've had patients in diabetes clinic go, you know what, I figured out food raises my blood sugar. So people can't always hear it, they can't take it in, they can't make it work, make it part of their paradigm or part of how they got to where they are. They just can't. It amazes me how long you can keep up a message and they can't hear it. So people hear about 20% of what you say. That's why you tell them, you give them a handout. We're hoping the pharmacist reinforces that. It's multiple times that they'll hear. If they bring someone with them, I will often have both of them tell me back, tell me the plan, and tell me why. So I do a lot of rehearsing at the end of a visit. I do a lot of playback. Okay, you tell me what the take home for the day was. It's just like you all. You will remember probably 20%. I can stand up here and go, I told you. Or I'm looking at the test and I'm like, I told about it. It's too much. You can't do it. Can't absorb it all. So you can empathize with your patient. Okay. It's never too late to get somebody to start moving. I was telling somebody in here, my dad's family all came from Czechoslovakia. So we went back there, and my dad introduced us to family. What struck me is that in the part of Slovakia that my dad family's from, it is very mountainous. The Tatra Mountains there, they're just huge. They have the lower, which are about 10,000, and they have the higher, which are about 14. So we would go hiking almost every day. These people smoked, they drank, they were all over 60, and they could run up the mountain, and I am like huffing and puffing, and I was in my 30s. So moving works. So if you look at that European study, after a 10-year follow-up, adults older than 70 who implemented the 4 lifestyle changes I talked about had a 67% reduction in cardiovascular mortality compared to those who adopted 0. The thing with exercise is it has to be current to be of any value. If you were an athlete in high school or college, it does nothing for you. Sorry. So you have to tell your patients that too. So doing it live is most important. Keep moving. All right, let's take a break and we'll come back and talk about the drug treatment on page 7 at 11. That's all I do. I look at the LDL. Well, when you're female, you have strong pheromone history?
My dad has
Okay. So they do total cholesterol to HDL ratios? Okay. So a lot of them will go by that ratio instead. So I've had the same thing since I was thinking of age, but now total cholesterol
My mom's had like 50 years. Radio died, so like so quality. I'm like, people freak out. They would have sent you somewhere.
I'm still not taking the money. Because the other man was I said, well, we were
but I never could do like every day at 5, like they probably just told me to. Oh yeah.
So I looked it up, so I was right, about 20 years ago, they took Intal off the market, and that was it was a drug, it was one of the first dry powder in the house. They had a capsule, put it in there, spun it. They took it off, which tells me it's more likely that the FDA did not require it to sell.
Good family friends are coming in town.
So, but.
my sister and I went to her too. Me and my mom went
Nebulizer solutions. It did go through a ton of just remember that there's some problem with some he got stuck about
Well, I just have the days keep up that
you probably have.
Maybe. Thank you. Is it a big cat? Yes, it's a cat. Is it like a cat that's borderline like leopard?
I feel like
I used to see people walk those around campus.
Yeah, really? That's why I don't like donuts. I'm not a
Yeah, don't do that. Especially with women.
a lot.
How much?
Much more stronger for men.
That's probably why I don't like
And they even.
Because I like cake.
Years ago, they get your bottle to
Do what?
I
I have a sweet tooth like
we
my
did
dad.
I have a sweet tooth, but I can only have like.
As I get older, I couldn't eat heavy,
So, because my boyfriend
Yeah,
has
that's false.
but you don't eat a lot of it. Or like this duck that with almond. Yeah, just put it in the freezer. Oh, that's so good.
Like I can't go to.
I think it's
probably and get like one of those.
Here's what the
Oh, God, no. I'd have to split that with someone else.
Or they just get. So they're giving up that.
Yeah, but what kind of you get? I like
You just go out there and try to.
Oh my gosh, you can get it there. Yeah, Blue Garden.
That was my like 6% of dollars.
Sorry, I have a question for her. I was going to ask her real quick. Because I feel like it's like
Wait, we learned about it.
I need actually.